guest presenter today is Charlie Chang, and she's going to introduce herself. Well, she's the president of the Coalition for Global Health Innovation. She's joining us from Cape Town in South Africa. I'm going to now to introduce the agenda, and let me see if I can make this larger. Yeah, can you see? Okay. So, welcome agenda, the objectives and expected results of the meeting. We're going to have an interactive presentation by Charlie. And after that, I will lead an open forum because we don't want only to address the problems, but we would like to get your ideas as to what could be done and what approaches you think will be necessary. Then we'll have the final remarks and conclusions, and then I have a question for all of you. A question that has not too much to do with this webinar, but with future webinars. So we are going to talk about epistemic justice, cultural humility, and also introduce the theme of decolonization, because those are conditions or needs in global health practice and research. And then I will say something about assistance, support, and collaboration, and I can tell you that right now. But we have people who have given technical and financial cooperation for a long time. Some of your mentors, Dr. Poncelet is here, and maybe some other mentors will join us. And what we expect is that at the end of the meeting, we will have a better understanding of what is the impact and the consequences of the lack of justice, this power imbalance, and the lack of humility on the part of many, many multilateral and bilateral agencies, including NGOs. And the main point will be to get your ideas on how to reduce inequity. Remember, inequity is inequality that is unjust and preventable. And this attitude that I really know everything and I'm going to make you do what I think is the right thing. And then the colonizer's mentality. And this is something not only international, but in your own country. Some experts may come to a community and have that kind of colonizer's mentality. Okay. I'm showing you this because I introduced Charlie since 2019. It was a meeting we had in Berlin where they started the Coalition for Global Health Innovation. And there were 23 young people from all over the world. We have Colombia, Canada, Romania, Germany, China, Kenya, and then Serbia. You will recognize half of this person because she's on the homepage of Multipod Mentoring. So without further ado, I'm going to let Charlie introduce herself and make her presentation and have a dialogue with you on these subjects. Before that, again, I would like for you to show us who you are. That's the way we get to know you. And then when you ask a question or make a comment, I would ask you to please give your name, where are you from, and then what are you doing right now, very briefly. Oh, I'm a student at so-and-so, and then make your comment or ask your question. Okay, Charlie, the floor is yours. Please.
Thank you, Fernando. Thank you, everyone, for joining today. I was thinking maybe we could stop sharing the screen because I don't have any slides, and it would be nice for me also to see everyone's faces on my screen. All right, thank you. So hi, everyone. Good morning, good afternoon, and good evening. Depends on where you are joining us from today. My name is Charlie Sitong Zhang. Today, I'm joining from South Africa. The weather is amazing today, so I'm really grateful. So I have a long history with Multipod. I was a mentee at Multipod in 2018, and later I served as one of the technical officers. And in 2021, I was the assistant coordinator at Multipod. And as Dizzy mentioned, because of Multipod, in 2019, I attended the World Health Summit in Berlin, Germany. It was a very prestigious event for someone at that time. I was very young. I was a recent graduate, and I get to see like the senior officials from WHO, from UN. It was really impressive for me. So I met some of the Multipod mentees in person, and we formed a coalition with the aim to bring together the talented young professionals and students from many different continents, and to amplify the voices of the youth in global health. And later, we registered the coalition as a nonprofit organization in 2021. So we are called the Coalition for Global Health Innovation. I have been serving as the president. Our mission is to empower young professionals and students in global health and international development by helping them to showcase their work in our online events and webinars and publications on our platforms, and help them develop their early stage projects in our pre-incubator CGHI Action Tank. And I'd love to invite everyone here to check out our website and connect with us on LinkedIn, Instagram, and YouTube. And you can also email me or message me here. I will share my email later. So a little bit about my background. I was born and raised in Southwest China in a beautiful city called Chengdu, the capital city of Sichuan province. We love spicy food. When I say love, like we love spicy food. At 17 years old, I moved to Europe for my higher education. I was so curious about the world. I still am. But at that time, I thought Europe is the center. I need to go to Europe, right? So I went to Europe. I studied there. I got my bachelor's degree. I was trained as a political scientist and sociologist. And then I got into global health through Multipod. And I have been focusing on health equity and medical anthropology. For the past decade, my academic and community work have been centered around justice, equity, inclusion, and community empowerment. So I lived in Europe for 10 years, Egypt for 2 years, where I was living by the Red Sea. I learned how to swim at 29 years old, and I also got 2 licenses, professional licenses in scuba diving. And it really humbles me because we as humans, we walk on this earth. We don't know so much about the world. We don't know what's under the water, right? So, and that also made me really in awe of our planet. So when we talk about global health, we also need to talk about planetary health and the ecosystem that we live in. Okay, so now it's my 2nd year in South Africa. I'm pursuing a master's degree in development studies at the University of Cape Town. So I recognize my privilege in the fact that I have been able to study, live, and work on 3 different continents, and whereas a lot of people are not able to move, right? Even if they live in a war zone, right? So, and I'm fortunate enough to have met and interacted with and learned from, studied with, worked with people from many different cultures and backgrounds. I think it's a really integral part of my life. So my life mission is to use this privilege to build bridges between different cultures and communities. And I want to invite more people to talk to each other, to learn from each other, that people we don't necessarily meet on a daily basis, right? And to overcome our biases and stereotypes, and we can work together. And I believe that systemic change towards true equity and inclusion starts from ourselves at an individual level, and our daily activism in the smallest unit we are in. So we think about our parents, we think about our siblings, our friends, our classmates, people we interact with. Start conversations, like start inviting people in instead of calling people out. I mean, sometimes name and shame is also necessary, but but at our personal level, we can start with inviting people in. So today, I am not going to give a lecture. Instead, my intention is to create an interactive learning and sharing circle where we could discuss and reflect on some of the concepts and ideas that I will be sharing today. And I would like to invite everyone to engage with me while I am talking. by sharing your ideas, comments, and questions in the chat box, or raise your hand, and I will invite you to speak. Okay, so we can start. So first, I want to ask everyone, how do you define health equity? So maybe, I don't know who I should invite first. Is there any volunteer? I will invite Anaili. I see you smiling, so.
Okay, just to introduce myself first, my name is Anaili Vaquero. I'm from Colombia, and as you can see in the screen, I'm the program officer at Multipod Mentoring. So thank you for joining us today. And answering the question, I don't think it's an easy one, but global equity. I will try to start with a simple description, just to save myself. I will say it is the capacity that everyone is able to access the same resources. I will say that.
That's great. Thank you. What about Maria? Do you want to share with us your ideas?
But me, I'm the only one. There are many Marias.
No.
I haven't checked, but
No.
yeah, I agree totally with Maria. I think it's the ability for each one of us from everywhere where we come from to be able to access resources and that have to do with health and everything really. The ability to be able to reach those resources and benefit from them equally.
Great. Thank you. And I see someone raised their hand. Eniola, if I pronounce your name correctly.
Hello. Sorry, I'm unable to turn on my video right now. But my name is Daniela Falami from Nigeria. And to me, health equity means that everyone has equal access to healthcare, regardless of their background, their location, and other determinants. Thank you.
That's great. Thank you. Thank you, everyone. So I don't see any more hands. So yeah, I hear the common things that we're sharing is that it has to be equal and same access to resources, to healthcare. So, but what about the inherent inequalities, inequities that in our society and in our societies, in our world, right? So there's a difference between equity and equality. So there are many word play, different definitions of health equity, but in essence, health equity means all individuals have the opportunity to attain their highest level of health, regardless of their social or economic circumstances. I'm sorry, I'm gonna mute Alberto. Can you mute yourself? Yes, okay. Yeah, thank you. Yeah, so health equity refers to the absence of disparities or inequalities in health outcomes between different groups of people, particularly those defined by social, economic, or demographic factors. It implies fair access to healthcare services, resources, and opportunities for all individuals, regardless of their background or circumstances. So health equity also includes the fair distribution of health resources and opportunities, ensuring that everyone has the same chance to attain good health and well-being. It emphasizes the removal of systematic barriers and the provision of support to marginalized and disadvantaged populations to address health disparities. So when we think about examples, we can think about like the vaccine inequities, right? During COVID, the rich countries, they were hoarding the vaccines, whereas poor countries did not have any access to the vaccines. So health and health equity are determined by the conditions in which people are born, grow, live, work, play, and age, as well as biological determinants, structural determinants, political, legal, and economic, with social norms and institutional processes, shape the distribution of power and resources determined by the conditions in which people are born, grow, live, work, and play, and age. This is the definition from WHO. So you see, like, it recognizes the structural determinants, political, legal, and economic, with social norms and institutional processes, right? So when we think about like social determinants of health, it's not just the biological determinants, but also like, are we living in the war zone? Is there any like access to political freedom? Okay, so people's living conditions are often made worse by discrimination, stereotyping, prejudice based on sex, gender, age, race, ethnicity, or disability, among other factors. Discriminatory practices are often embedded in institutional and systemic and systems processes, and leading to groups being underrepresented in decision-making at all levels or underserved. Progressively realizing the right to health means systematically identifying and eliminating inequalities, inequities resulting from differences in health and in overall living conditions. I'm not going to talk too much about that. But yeah, like, one last thing is that research has shown that social determinants of health can be more important than health care or lifestyle choices in influencing health. For example, numerous studies suggest that social determinants of health account for between 30 to 55% of health outcomes. So when we work in global health, when we do research, when we do our work in global health, we need to be aware of the systemic inequities, and we need to be advocates for social justice at the same time, right? Healthcare does not exist in the vacuum. And so justice in health encompasses the broader societal and structural factors that influence health outcomes and focus on addressing the root causes of health inequities, such as poverty, discrimination, and social injustices. It advocates for systemic changes to ensure fair distribution of resources and opportunities, prioritizing the most vulnerable populations. So global health professionals have the ethical obligations to advocate for social justice. So now I want to talk about epistemic justice and epistemic injustice in global health. So first of all, what is epistemic justice? So epistemology, this word means the production of knowledge and the dissemination of knowledge, like who is producing knowledge, what kind of knowledge is considered as authority, as expert, and who are distributing the knowledge and who are understanding, interpreting the knowledge. So epistemic justice refers to the fair treatment and recognition of different forms of knowledge within society. It encompasses the idea that all individuals and communities should have their perspectives, experiences, and ways of knowing respected and valued. Epistemic injustice occurs when certain forms of knowledge or ways of knowing are marginalized, ignored, or discredited, leading to unequal distribution of epistemic resources and opportunities. And in the context of global health, epistemic justice and injustice refers to the fair treatment and recognition of diverse forms of knowledge, expertise, and experiences within global health. Entails epistemic justice in global health entails acknowledging and valuing the insights and perspectives of individuals and communities from diverse cultural, social, and geographical backgrounds, and recognizing the importance of local knowledge systems, community-based approaches, and indigenous practices in addressing health challenges. So we need to think about, for example, traditional Chinese medicine, for example, the traditional healers in some tribes, right? Like how they play an important role in the healing. And actually recently, I'm taking local language classes in South Africa, and I learned that in the local language in Western Cape province, in Eastern Cape province, there's no way to express that I have headache, I have pain in my head. And the way people express that is to say, I have a head, I have arms, I have a stomach. That means I have pain there. So that's very interesting. And when we have like experts or volunteers from other cultures, from the global north, when they come to the global south, when they come to villages, to some traditional tribes, when they think they are bringing the knowledge, of course, they might bring some knowledge, but at the same time, are they truly understanding the needs of the locals, right? We need to ask ourselves that, like, how do we bridge the gap in our understanding? And when we are lucky enough to be welcomed into other people's community, what are our blind spots? What are our privileges? What might be our misunderstandings? And how can we serve better? How can we understand people better so we can serve better? So now I want to, I want to give a few examples of epistemic injustice in global health. So when we look at the health journals, global health research, the journals are most of them from the global north, and also the publications, the papers that are being published, the research that receive the most funding, are they mostly in institutions from the global north? Are they mostly researchers from the global north? Are they also trying to work with universities, research institutes, and community workers from the global south? And also, when they do collaborate, are they using them as tokens, right? Are they really honoring and centering the knowledge from the ground, from the people from this community? So these are all the things that we need to consider if we want to be an ethical researcher, a practitioner, and also on an individual level. There is testimonial injustice. So many research, many studies have shown that there is a unconscious biases among medical professionals where they hold stereotypes about, for example, Black people having a higher pain tolerance, and thus the medical professionals are less likely to treat the pain from their Black patients. So that is when we are not honoring the stories that people are telling us, I am in pain, I need painkillers, I need my pain to be treated. So now I want to talk about cultural humility. What does cultural humility mean? Cultural humility is a mindset, an attitude, a lifelong commitment to reflect on our prejudices, on our biases, on our blind spots. It involves recognizing the inherent power dynamics within social interactions and acknowledging that our own cultural perspective is limited and may not fully capture the complexity of another person's lived experiences. At its core, cultural humility requires individuals to approach cross-cultural encounters with an open mind and a willingness to engage in genuine dialogue, actively listening to others' perspectives, and valuing their lived experiences and personal truth. It emphasizes humility, recognizing that no individual can ever fully understand or represent the entirety of another person's cultural identity and lived experiences. Cultural humility encourages a stance of curiosity, empathy, and openness to learning from diverse cultural traditions and beliefs. And practicing cultural humility involves a range of attitudes and behaviors, including acknowledging one's own positionality, social location, privileges, blind spots, biases, and prejudices, and challenge our own assumptions and refrain from imposing our own cultural norms onto others. So positionality is the notion that personal values, views, and location influence how we understand the world. In this context, race, nationality, gender, class, sexuality, and other aspects of identities are indicators of social and spatial positions and intersect with other qualities we have, other social locations we are in. Our positions act on the knowledge we have about the world, both material and abstract. Consequently, knowledge is the product of a specific position that reflects particular places and spaces of that person and that community. So that is inviting us to think about, okay, like my, let's say my background, where I'm coming from. That comes with, sure, my heritage, things I'm proud of, but also limitations in how I understand the world and people that's not from my culture, right? That I did not grow up with. I might be less likely to be able to understand how they see the world, the obstacles they experience, the oppression they face, right? The discrimination they face. So privilege is actually more about the absence of inconvenience, the absence of a challenge, such as, and as such, when you have it, when you have the privilege, you don't notice it. But when it's absent, it affects everything you do. So when we talk about like white privilege, it's the absence that they might not be subject to police brutality, right? And when we talk about male privilege, we're not discrediting that a male cannot be victims of sexual violence, but rather the fact that, statistically speaking, women are more likely to be sexually violated. So it's the absence. Privilege is the absence of inconvenience. So there are a few important questions that we can ask ourselves. How does my identity shape my worldview? How I see the world? What privileges or disadvantages do I experience based on my social location? What advantages do I have based on my identity? How does my privilege impact my perception of the world and the people in it? And what responsibilities do I have to address and mitigate the effects of my privilege? And at the same time, what kind of networks, what kind of communities, what kind of resources I can tap into because of my privilege, and I can use that to help others who don't have that privilege. So cultural humility extends beyond individual interactions to encompass broader systemic change. It calls for the recognition and dismantling of institutional barriers that perpetuate disparities and marginalize certain underrepresented groups. This may involve advocating for policies and practices that promote diversity, equity, and inclusion in the knowledge production and decision-making process. So ultimately, cultural humility is a transformative process that fosters mutual respect, empathy, and collaboration across cultural boundaries, and embracing humility and a willingness to learn from others, and we can do better in everything we do. So that is the end of my part for now. I want to invite everyone, if you have any comments, if you have any ideas you want to share, if you have any personal stories that you want to share, the floor is yours. Thank you. Maria, go ahead.
Sorry, I can't find a hand to just raise it somewhere. I just wanted to say thank you for describing so well and so incredibly accurate all this knowledge that you have, because I think you have really encapsulated a lot of words and a lot of meanings that is exactly that. And one thing that resonated with me was when I was studying global public health. One of the things that I learned and that I was able to discover my own biases about this was about the fact that most of the journal papers, as you said, were coming from the global north, and this huge disparity between what was produced. And I thought that was incredibly wrong. I thought, oh my God, we have just completely twisted distortion of reality here. I mean, all of us were involved in this, and we are still doing it. I mean, what can we do to mitigate this? And when I read more about academia and well, things that I didn't like that much, it really shocked me, because I think this the dissemination of knowledge and the studies obviously are important for evidence-based practice, and if we are relying on that to promote new policies and new ways of thinking, we are kind of doomed, aren't we? I mean, that's my personal feeling, and that's what I learned. So from that point, I think I've been trying always to figure out the ways in which my brain is trying to twist my own thinking and, you know, distort my own reality, and knowing my own biases. And it's become like a quest for almost everything. You can't go crazy with this, because otherwise you just wouldn't move, right? You just, as long as you increase your awareness and you put into practice the things that you think you have discovered, I mean, we're onto something, I guess. But it's a huge quest. I mean, trying to mitigate all those disparities between global north, global south, even the fact that we are naming sometimes some countries in development lower middle income countries, you know, you read it in all the papers there, that for me is already discriminatory. If I was belonging to one of those countries, I would be thinking, it's not a lower country, this is a country that is actually implementing very important things, and your country is not doing these things. So they have an incredible power on my own view. Well, I just wanted to share that.
Thank you, Maria. Thank you. Yeah, I think as an activist myself, in the activist circles, we always talk about the burnout, because there are so many things that we want to do. So we also need to take care of our mental health. And I think a good way to do it is to look at the smallest thing we can do, the smallest circle we are in. And also, like, I think in this case, if I were a researcher from the global north and I have a lot of funding, for example, then I would like to invite more researchers to join me from the global south who might not have access to this kind of opportunities. And yeah, these are the things that we could try to do, right? And then also, like, researchers from the global north, they could also try to attend conferences and seminars, online events organized in the global south, also to bring more exposure and funding to the parts of the world that are less represented in the research and the field. Yeah, thank you. Anyone else? Feel free to unmute yourself and go ahead. Deborah, I see you.
Hi, Charlie. Thank you very much for your presentation. I just wanted to share a couple of experiences that I have. So I'm Deborah. I'm Nigerian. I'm doing my PhD in Lisbon. So I was lecturing in the university in Nigeria before I came to Lisbon for my PhD. So I conducted a couple of research studies and published a couple of them before I came. And I always had to deal with this, well, I would say discriminatory, because I would, conduct a study with out-of-pocket funding because I was early career researcher. So I didn't have funding for big studies. And I would always have issues with the editors who would say that your study doesn't have a lot of global relevance because it's conducted in perhaps a small city in Nigeria, or in a state or two in Nigeria. So, and I felt it was discriminatory because I would see studies of even less quality, but because they are conducted in high-income countries, they get to be published in such journals. And don't even get me started about APCs. Sometimes you don't even get past the editorial stage because you can't afford the APCs. So that's one point. It's a huge inequity that happens. I mean, you don't get to even have the opportunity to publish in certain journals because you're automatically disqualified. You can't afford to pay the APCs there. That's one point. Then the other point that I could relate to was epistemic injustice. So my background, I'm a pharmacist, and I know that there are plants with pharmacological activities that the traditional healers use. I also know that these plants usually occur in concussions, so they are not standardized or isolated compounds, but it doesn't change the fact that they have pharmacological activity. So we can talk about the fact that they might have side effects and things like that, but these plants are effective plants, but they never get to see the light of the day because it's all lumped into it's traditional plants, it's fetish, and it's this and it's that, and we don't see a lot of recognition for these plants. I'll give you a practical example with iboga. I don't know if anyone here heard about iboga. So it grows in, I think, Congo or so. And the pygmies, they use it for a lot of ceremonies, but no one talked about iboga until it started to be exported. And now in Lisbon, there are iboga ceremonies. You get a lot of people coming to Lisbon, paying thousands of euros for iboga ceremonies that come from Central Africa. And, if I said that a traditional medicine man in Congo was doing that, it probably wouldn't get any recognition. But then it comes to Lisbon and it's 3,000 euros for iboga ceremonies. So yeah, I just wanted to share that.
Thank you, Deborah, and thank you, Charlie, for this very, very comprehensive and very tight and specific conversation. I just would like to say regarding that, just a few words. We talk about generation of knowledge. That is research. And some of the problems we have seen is, for example, the exclusion of women in research. I don't know if you know that until 34 years ago, women were not studied except for gynecological conditions. All the studies were done in men. And the reason for that is because it was very expensive to study women because of their cycle, hormonal cycle, or because they could get pregnant. So women were excluded. So everything we knew about hypertension, diabetes, etc., came from studies in males. And the same thing about car accidents or whatever. The dummies they used for the accidents were all on the shape of men, but the only thing they did was reduce the weight of the dummies, thinking that those were women without taking into account the size of the women and the shape of the women, which is not the same. As a consequence, there were more women subject to injuries and death than men in the same conditions, in the same situation. The other point about research is the ethical committees. We did a study in the late 80s with 5 countries in Latin America, And in 3 of them, we had to start an ethical committee because there was absolutely something that they never thought about when they were conducting research. But I would like to now to go into the practical aspects of what Charlie has been talking about. And instead of talking about the problems, I would like for all of you to think about solutions or approaches to make conditions better. And I don't know, Charlie, if you're still sharing the screen, because I would like to, no? Okay, so let me see how I can go to share my screen. Okay. Okay. So after Charlie's presentation, I'm going to move fast and then we can open the floor again. So I'm going to present not only what I wanted to present as examples, but just give you some remarks that you can think about solutions. First, we fail. Many times we fail in our projects. No matter where you are, sometimes we fail. And there's a group like Doctors Without Borders, Engineers Without Borders in Canada. And they used to publish every year their failure report. And you can see the report on 2013, Striving for Humility. So they tried to find a way to reduce arrogance, cultural arrogance, intellectual arrogance, technical scientific arrogance. And as you can see in the index, failure to learn, striving for humility to achieve big dreams. And there were also something about the Canada. In Canada, they also have to learn about humility. Programs that they had in countries in Africa, it was the same. How to be transparent, how to make sure that you could monitor and evaluate what was going on. The reason I wanted to present this is because I want you to think in those terms. And I'm going to give you one example. In one country in Africa, and the images that I'm going to show you are not necessarily from a country in Africa, but just to emphasize and to show you what I would want to talk about. You look at this area and you can see that the soil, there's absolutely nothing there, but there's water. So these engineers went to Africa, to that community, to help them. According to them, this is what they wanted, that was possible, and this is what the people in the community have. So very smart, very intelligent, very good experts told me, okay, why don't we teach them what to do? And of course, this is what they did, and they were very proud of that. The community didn't want to do what the experts advised, but they kept talking and talking and talking with the leader of the community, with everybody, and finally they persuaded them to do what they wanted to teach them to do. How to build irrigation canals, fertilize the soil, plant seeds, tend to the fields, and be ready to reap when the time comes. And then prepare for the feast, because they were going to have vegetables to eat and they will be in charge of their own destiny. That sounds very grandiose, but that's what they wanted. Now, what happens? This is Africa. The results were beautiful. But the experts from Canada didn't think about hippopotami. Here they come. Here they come. And thank you. In one night, they destroyed everything that they had planted. So they thought again and they said, oh, maybe if we put some kind of barrier, or if we plant, I don't know, 1 kilometer or half kilometer from the water, we will be okay. But then the hippopotamus, and these guys from Canada, they know they can walk up to 10 kilometers to find food before they return to the water. So they learned that lesson. And where they failed is they didn't ask the community what were the possible solutions, what was the real problem. What was the real problem? Why they didn't do what they could have done, according to the experts. So this is what I wanted to show you, because it's important. And now I'm going to give you a framework for ideas. And most of you know this. This is a problem tree. And Charlie alluded to that when she talked about the social determinants of health. Well, here I want you to think about, first, the main problem. What is the main problem in health, for example? Let's say that there are children who are infected in the community, have diarrhea, and then they come to the hospital because they are dehydrated or they are dying. And then the doctors here treat the consequences. But the main problem is the infection in the community, typhoid, Escherichia coli, etc. Then you go to the causes. Why are those children being infected? Because they live in an environment that has lots of bugs, there's fecalism, everywhere, and the children are playing on the ground and they get infected, the water is contaminated. So this solution is medical. This one has to involve the community, but the community has to be here, and this is not a medical problem. This is a social problem. This is a structural problem. Engineers are the ones who could bring good water here. So I want you to think about that, but even that is not enough. Problem tree and solution tree. The problem tree, okay, you have to do it, and you start by making sure that you know that the problem is a problem and that the problem is the problem. But then you go to the solution tree, and here you have different types of interventions, and you can work on the consequences, on the main problem, or on the causes. And many times, we only work on the consequences, or we try to work on the main problem. What we don't talk about the causes, because they are so difficult. If you talk about gender issues, gender discrimination, etc., you talk about that. You make interventions here, and you make interventions here. But many times you don't think about what causes that. Okay. So that's a framework for discussion, but I'm going to tell you something else that I was thinking about my closing remarks, but I prefer to talk about this. Many of you are going to be working in ministries of health, are going to be working in ministries of finance, are going to work in NGOs or international multilateral organizations, WHO, UNDP, etc., or bilateral organizations, Spain giving support to Latin America, to projects there, or in Africa, for example. And you are going to become consultants. So I want you to think about this. What is a consultant? It's a problem solver. You are going to solve problems. You are going to advise, but you are also going to learn. And you are also going to teach, but with humility. And the practical point of this is that if you are a good consultant, you define the problem and you make recommendations what to do to solve the problem. You must do this. Now, if you are a better consultant, you define the problem and its causes and makes recommendations of what to do to solve the causes. And of course, the problem. But the best consultant, and that's what we want you to be, no matter in what position you are in your professional life, the best consultant uncovers and defines the problem and its causes and makes recommendations and helps and gives support, not only what to do, but on how to do it. how to do it. That is something that we forget. I have worked 55 years, 40 of which have been giving international cooperation in health, in international health. So this is something that I want you to think. Now, what could be a remedy? As Charlie said, the remedy is within ourselves. If you are going to help a community, a country, or your whole country, because you are the Minister of Health, you need to have professional qualities, knowledge. Knowledge is what should lead to policy, is the evidence-based policy. And policy are the rules of the game. But that has to lead to action. And your action has to lead to impact, because that's what you want. So it's not enough to do the research. How does that research translate into impact? The diffusion of knowledge, for example. How they start in the developed countries and then they go to the lower income countries 10 years later. Now with the globalization, it's easier. Intelligence, you are in the program because you are very intelligent. You have that ability to learn, make comparison, and identify patterns and relations. That's what your intelligence is. And then you are acquiring experience. Repeat, 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 repeat until you become a master of what you do. They say with 10,000 hours of doing what you do, you become very proficient at doing that. But you also need to be curious. What are the questions? The main question. And those questions, do they lead you to answers or to new questions? And then you need to observe and make your research. And you have to be assertive. You have to have the ability to persuade, to convince people. And that's the expression of your technical authority. You go there because you are a pharmacological expert, and I'm not afraid of that word. But you are going to ask, you are going to be humble when you go to a country or to a community. But most importantly, and again, this is something that Charlie talked about, what are your personal qualities? What are your personal qualities? Empathy. When you can feel as a professional that the problem is now your problem, and now you are part of the solution, don't wash your hands, you are there. Diplomacy. Maybe you find that people have no idea. They are ignorant, and there's corruption. Well, diplomacy is you use good words about something that is bad. Okay, what you are doing is fine, but you could improve if you did this, or why don't you think about what is diplomacy? And then humility. Sometimes you are wrong, don't know, don't understand, or can't do it. When I started my career as a consultant, as an international consultant, I was a true expert because I was at CDC, Centers for Disease Control, and we did the research. And I was there when the AIDS epidemic was discovered. So nobody knew about AIDS, including ourselves, but we were conducting research on that. And then you need to have resilience, resistance against frustration and your negative emotions. I will give up. It never happens. And then patience. Time takes time, and you have to wait. Sometimes you don't see the results as soon as you want it, as fast as you want it, as rapidly as you want it, as efficiently as you want it, as effectively as you want it. So think about this and think about solutions to the problem. We are close to the end of the hour, but I wonder if a few of you can stay a few more minutes, because what we want is to get some of your ideas about what to do, about absence of humility, about inequity, and there's one thing that is very important about inequity. There is inequalities that are unjust and preventable. And Charlie gave very good examples with vaccination. And you can see that in many other conditions. Why should a poor man die at 55 and somebody who is white in the rich country lives until 81 or 78? Why? Okay, I leave you with that. And Charlie, I don't know, can we take 5-10 more minutes for somebody who is dying to say something? I think I'm going to stop sharing. I'm sorry it took me a long time. And
I would like to say something, please.
Okay. Alberto is a mentor, and he's back with us, and we're delighted. Okay, Alberto, please go.
Thank you. Thank you very much for everyone who has said so interesting words and the speeches, in particular, Charlie from South Africa. I just want to emphasize something following Fernando's comments, is that in public health, we know from 30 years ago that primary health care, PHC, is one of the most important strategies to give power to the people. But unfortunately, primary health care has not been implemented, has not been applied properly in basically every country of the world. It has been partially applied in some countries. Actually, here in Latin America, I am talking from Cali, Colombia. In Latin America, we have some examples of primary health care implementation that gives the idea of what exactly is. You must know, all of you must know, that primary health care has been reviewed by the WHO and the Pan American Health Organization, and they have produced, they had published documents about the renewal of the PHC strategy. So following your comments, I do encourage you to read more about how primary health care can help in giving power to the people, in giving the community options to do what they think have to be done in terms of health. And when I talk about health, I'm not talking about a health center. I'm talking about what exactly in the broad sense health means. You have spoken about social determinants of health. Exactly. I totally agree with that. So my comment was in that regard. Thank you very much.
Thank you, Alberto. Somebody else? I can see my friend Molly. Are you there, Molly? Yes.
Can you hear me?
Yes. Let me tell you something about Molly. She's the most sought after in the program. And because of that, it is her problem. It is her problem. So many people chose her as a mentor that we couldn't disappoint 16 people. So we only gave her 4 minutes. She graciously accepted them because we didn't want to disappoint so many people. Okay, Molly, please go ahead.
Well, you're so kind. I'm the lucky one for sure, and I hope I don't disappoint the mentees. But I just wanted to I just wanted to applaud Charlie for this fantastic conversation. And I think I love that the ideas of solving, working to like identify and understand and solve and find solutions to these complex issues are have to come from the people that are affected. And I think collaboration is always also good because it can offer different perspectives. So yeah, I think I just am very happy to see this conversation and applaud you, Charlie, for initiating it, and Fernando for for hosting and creating this space for everyone to collaborate, with diverse kind of experiences and diverse, geographies and things. So yeah, thank you so much. I really feel honored to be part of this. Thank you. Congratulations, Charlie.
Okay, thank you. There was, I think, Eniola wanted to ask a question. I don't know if you are still there, Eniola.
Sorry, me?
Oh no,
Sorry.
I was not going to ask a question. I was actually applauding you. I was enjoying the presentation.
Okay. Well, one thing I'm going to ask you before everybody leaves, Anaili is going to be very mad at me if you don't turn your cameras on and we can take a picture. Because almost half of you are just in black. Do you have any problem with your cameras? Okay.
It would be great if you can just turn on.
Mohammed, how are you, my friend? Okay.
Hello, everyone.
Mohammed is from Sudan.
Yeah, I was about to raise my hand to share something. If you allow me. Thank you, Charlie, for the presentation. It was really a very interactive presentation, and the knowledge that you shared is very interesting. For me, I worked for 3 years for the Federal Ministry of Health. I started working at the federal, and on my second year, I started working on state level, and also at the locality and health facility level, working to strengthen the health system within my country, especially on the term of the supply chain and focusing on the issues related to the service delivery. I remember for me, working at the federal is totally different when you go on the ground to understand what the community needs, especially on the issues related to primary health care and see how health cadre, the challenges that they face and how they need to serve their community. And I think I remember this Muhammad Ahmed. I met him during my mission to Darfur. He was studied at University of Khartoum. He had a very interesting story. Studied for 4 years in Khartoum. He coming from Darfur region, and when he get back, he found out his community and the village that he is living, they need some doctors to help them to access the service delivery. So he changed that and he studied additionally 4 years in health, and he became a health cadre. And he's starting building with the community leader a health facility. So he almost helped like 7 or 8 villages around him, and because there were issues related, the high mortality and high morbidity in, Darfur region, and when you need to access to health services, you need to travel like at least 1 or 2 hours to get access, and sometimes you couldn't find a petrol or a car that you travel to another health services. So it's for me, I was really proud at that moment to meet him, and he's not boring. He's serving his community for 5 years and still continues and improving the health. And he showed us a hospitality because he believed that what he do, so many people just like him can do that. And for me, the knowledge that I get from the community, like in low and middle income country, I know that Sudan is a very complex in health issues. And for me, I travel a lot during states. I visit around 16 states. And when I travel from state to state, it's like I travel from a country to country because in some region there is issues related to political, economic, and security. So totally different when we go on ground to understand what the community need, what the challenge they have, and how we could help in the solution. And when we tried writing a report and compile them and sharing them at the federal level, I think sometimes there were some issues with inequality because we don't need like to treat state at similar because there were some difficulty in some state in terms of access to a lot of things. And this is remember me when I was in the border between Sudan and South Sudan. There, like a city is called Kadugli, and when we need to like transfer or transport medication for another locality, and it could take like more than 1,000 kilometer, and for a distance it's like 50 kilometer, but during the security reason we cannot deliver that. We have to change the the road of delivery. I feel like how could like see how could politics and security like affect the health issues and on the ground. And this is why every time it's motivate me like yeah, I know the challenges, but if you don't sit on the ground with the community to understand their issues and their challenges, you cannot help them, because
You're absolutely,
they were gap of,
right. You are absolutely right,
yeah,
Hamid.
yeah,
Thank you, because we know the situation in Sudan and what you
yeah.
have been doing there and your ideas about that. But I would like to ask Akpaka or Eniola to say a few words, and also Antidius, if you want to say a few words. We are over the time, but we can take 3, 4, 5 more minutes, because we would like to hear if you have a question, if you have a comment, if you have any ideas. And please feel free to talk, because we are friends. This is not a big meeting. We're having coffee or Coke or whatever. So feel as if you are talking with friends, because public speaking is very, very difficult. So please don't have any qualms about talking. Okay? Akpaka. We call you Akpaka or Geraldine or what?
Yeah, so Geraldine is my, you can call me Geraldine. Akpaka is my family name. Yeah.
Okay,
Yeah.
good. Thank you.
Okay. So hello everyone. My name is Geraldine. I'm from the Republic of Benin. Well, I don't have any question or comments. Just to say that I enjoyed the presentation. It was a good presentation, and I learned, yes, from this presentation, because I'm currently studying a master's in public health at Tokyo Medical and Dental University. So it was an opportunity for me to learn. And well, there were things I could, even though they were not personal experience, that I could relate to in what she explained. So for now, I don't have any questions, no comments. Thank you.
Eniola, we want to hear your voice. We want to hear your voice and see the smile. I'm so envious whenever I see young people with those smiles.
Thank you. I actually really enjoyed the presentation. Just like Geraldine, I also do not have any question, but I really did enjoy the presentation, from yours to the guest presenters on too. And yeah, I think I'll be reaching out to, is it Charlie? Yes, I hope I pronounced that right. I think I'll be reaching out to her to talk more about her work with her organization. Thank you.
Okay, great, Eniola. Well, if there's Dr. Farai, yeah, why don't you say a few words? Since we didn't see you before, please say something.
Yes, thank you so much. I couldn't turn on my video before, but my name is Dr. Faria, and I'm a doctor by profession. Currently, I'm pursuing master's in public health, and I found today's talk and dialogue very relevant to something I am basically studying and I'm researching about, especially in terms of global health. Currently, I'm working as a digital health lead at a digital health tech startup in Pakistan. And we're basically trying to tackle health inequalities through digital health means to improve accessibility, affordability, and access to healthcare services in urban and rural areas of Pakistan. So I found it very relevant and very interesting.
Wonderful. And you know what? We are so thankful because you are the first person from Pakistan who joins the program. And I have been trying to get somebody from Pakistan because we also want to learn about your experiences in your country. Okay, I would like to pass the microphone to Charlie to say something, and then we close the meeting.
Thank you, Dizzy. Thank you, everyone, for joining today and for, listening and sharing your ideas and comments. It was a pleasure to meet everyone, and I shared my email and our organization's contact information in the chat box. So please feel free to reach out. I would love to connect with you. Yeah, I think at the end of the day, there's cultural humility, epistemic justice, and there's also like, I think some of us here, we also feel like our truth is not really represented in the mainstream research or mainstream advocacy. So we also need to take that space, be proud of our truth, and also speak about our truth, right? So, and my presentation today was more about like cultural humility is more about someone who is coming from a privileged position and going to the community. And even if like we're talking about the context of Global South, someone could also still be like the fact that they had access to education. The research participants they interact with and also the patients they interact with might not be able to have, education. So then we come from a position of privilege, and how do we honor the truth of the people that we might not fully understand, right? So I think that's why we talk about intersectionality. Like it's not just, okay, race is one thing, gender is one thing, education is one thing, but how they intersect with each other and shape our experiences living in this world and what we can do.
Wonderful.
Together. Yeah, thank you.
Thank you, Charlie. I don't know, we are a few of us, but the other people missed the opportunity to be in a photograph. So can we take a picture of everybody? Antirius, can you access your camera? And Jeremy is another mentor from Barbados. If not, you will be just your name. Okay. Take the picture.
Yep. So Maria, we wait for you because we see the black screen. Or you can just smile. We pretend that we can see you. Okay, so everyone, if you can smile just for 3 seconds, keep that pose, please. So 1, 2, 3. That's it. Beautiful. Thank you.
Thank you, everybody. And we'll see you next time. My question was about the theme for the next webinar, because we have the possibilities of, well, we have one already set up for on implementation science, but we wanted to give one on the 4 brains of women, and another one on artificial intelligence as the next wave. But the speakers have not responded. We are expecting to finish details on implementation science, which is the key word now going on. And you will be invited, it's probably going to be at the beginning of June. And yeah, that's it. Thank you very much, everybody, and especially our speaker, Charlie. You did what we needed to do. You have shared your knowledge, and now we are ready. Now we are ready. Thank you very much, and everybody, have a nice day. Those who are late in the evening, go to bed now. No, it's too early. It's too early. And then we'll see you next time. Take care.
Thank you, everyone. Bye-bye.